So it's a great pleasure for me to have the opinion here on the possibility to present our data, to share our experience from German Heart Center with prediction of right ventricular failure during LVAD implantation. As I have no disclosure, I will speak about the evolution of the VADS strategy in the last 10 years, about the prediction of right ventricular failure, its current value, about the possibility to assess intrinsic right ventricular function, about the decision to temporary RVAD, and about the weaning from RVAD. Our center is a high-volume center, and we aimed to put the right ventricular failure incidence below 10% about 10-15 years ago, but incidence is still high. We try to predict, we try to new management strategies, but the incidence of right ventricular failure is still a huge problem. In the time 10 years ago, this risk stratification was really important to decide for the type of the device. If the patient had high risk for right ventricular failure, we decided for pulsatile device to have the option to implant another one later if the patient developed right ventricular failure after LVAD. Nowadays, the situation changed completely because it's a possibility to implant non-pulsatile LVAD like centrifugal pump hardware on both sides. So nowadays, we assess the risk, we predict the risk, we implant LVAD. If the patient develops immediately after LVAD implantation right ventricular failure, we implant temporary RVAD and then try to wean temporary RVAD. If this is not possible, in the time in about 2 weeks, 1 month, we implant non-pulsatile long-term RVAD as a solution. This also the numbers has changed in our clinic. Nowadays we implant just 1-2 primary biventricular assist devices. Rest is primary LVAD and if necessary temporary RVAD. What is the question is, why do we need predict right ventricular failure if the strategy has completely changed? This prediction is really helpful for choose of the surgical approach. If the patient has a low risk, we can choose the strategies like implantation without CPB from bilateral approach. We can choose strategies without CPB, just using ECMO for implantation or ECLS. We can guide our pharmacological therapy. Has the patient a high risk, we take additional drugs, additional monitorings in the therapy. We decide for the tricuspid valve repair, and very important, the early decision for temporary RVAD implantation. There are different definitions of right ventricular failure. What we need clinically is, in front of all, definition using these parameters, hemodynamic parameters, also the degree of inotropic support is important, and additionally echocardiography. So these 3 points, echocardiography, hemodynamic, and need for inotropic support, degree of this support are nowadays most important to define right ventricular failure immediately. So because there are also older definitions where one of the points in the definition is need of inhalatory nitric oxide for more than 14 days. It's not really clinical usable for us if we want to decide intraoperatively. So there are different ways how to predict right ventricular failure. There are shock parameters, hemodynamic parameters, echocardiographic parameters, and also the combination of many of them, and many groups try to describe different scores. The problem of these scores is that usually these scores are working very well in this group retrospectively, but if we try to use it prospectively in our group, it doesn't work. So it's not really clear why. I just will speak about 3 of them. Last 2008, older one is a score from